Cancer Community Tumor Board tonight. We look forward to this conversation with you and welcome your questions and comments in the chat box, and there will be plenty of time for interaction. So to introduce you to the Breast Cancer Tumor Board that takes place across the Yale network. These are weekly meetings of breast cancer team physicians, nurses, social workers, physical therapists, nutritionists, and others engaged in the care of women and men diagnosed with breast cancer. These tumor boards allow us to ensure that the highest quality multidisciplinary care is taking place in the care of you. And these meetings also serve to review available clinical trials. So today we'll give you a taste of what a breast cancer tumor board might look like and use it as an opportunity to teach you the latest about breast cancer management. And so in this tumor board, we'll present 2 cases, each representing different aspects of breast cancer care and patient experience. And we have assembled a multidisciplinary team from all the important disciplines that take care of patients with breast cancer. And as I mentioned before, as questions come to you, feel free to put them in the chat and we will all take turns answering your questions. So to introduce you to the members of the multidisciplinary team who are present today, I would like to first present Dr. Kevin Du, who is the Associate Professor of Therapeutic Radiology. He has specific expertise in radiation oncology questions related to breast cancer. We also have Dr. Kathleen Fenn here today, who treats a number of men and women with breast cancer and specializes in this area as a medical oncology expert. Next, we have Pam Fitzgerald, who's a licensed social worker and an oncology patient navigator. And through her expertise, she helps patients navigate a complex system and the overwhelming time that a breast cancer diagnosis can be, so that all resources are found and that your needs are answered. Next, we have Amanda Ganzak, who is a genetic counselor and outreach coordinator in Bridgeport Hospital. As you'll learn, there are many genetic questions that come up in the routine care of patients with breast cancer, and she'll be available today to answer those questions. Next, we have Dr. Melanie Lynch, who is the Director of Breast Surgery at Bridgeport Hospital. She is an amazing resource in our network, and we're very thrilled to have her expertise in the management of breast cancer patients. And next, we have Dr. Melissa Mastriani, who is an assistant professor of plastic surgery, who also has extensive expertise in managing all aspects of reconstruction and plastics issues that come up in patients diagnosed with breast cancer. So this is our team today, and this same team takes care of patients in the Trumbull-Bridgeport region. So if you are a patient in those areas, you may have already interacted with this stellar team. Since this is Breast Cancer Awareness Month, I will share a few facts with you, which is that over 300,000 individuals are diagnosed with breast cancer annually in the United States. There are over 3.5 million breast cancer survivors, and long-term survival after breast cancer treatment is common, with over 80% of individuals with breast cancer living more than 10 years after diagnosis. So with that, I will turn it over to Dr. Lynch, who will introduce our first case. Thank you.
Thank you, Dr. Lustberg. This team gets to work together every week, which is the best part of my job. So I'm glad we get to share this tumor board with you tonight. Our first patient is a 62-year-old woman who has an abnormal screening mammogram. She was called back and had diagnostic imaging that identified a mass in the left breast, the upper inner part of the breast near the chest wall. She's otherwise very healthy with only osteoporosis, and the only medication she takes is for the treatment of her osteoporosis. So the next slide. Her family history is interesting. Her mother had breast cancer at the age of 68, and her mother's brother, her maternal uncle, had pancreatic cancer at the age of 60. She has a very normal physical exam, except for a very small mass that can be felt in the upper inner part of the left breast, and she has no concerning lymph nodes on physical exam. So here's a representative. These cases are also representative cases. These are not specific patients, but here's an example of a mass that would be concerning on a mammogram. Mammograms are taken in two views, and so the first view looks at the breast from side to side, so you can see that the mass is in the inner part of the breast. And the second image shows the breast from top to bottom, so you can see that the mass is in the top of the breast as well, and very close to the muscle of the chest wall. The ultrasound showed this mass, and as you look at the ultrasound, you see the stripes on the bottom of the screen. That's the muscle of the chest wall, so you can see again that this tumor mass is close to the muscle. So she had a biopsy, and the biopsy demonstrated that this area was a breast cancer. It's a ductal cancer grade 2, and it's estrogen receptor positive, which is a favorable tumor biology. So this is where patients will usually see a surgeon as first course of treatment. And so we'll review medical history, surgical history, or social and or family history. And then we'll make, surgeons will make the referral to the tumor board for discussion of the primary team. In general, someone with a good early stage and favorable biology cancer will be referred for surgery as the first course of treatment. So I'd like to turn it over to Pam Fitzgerald, who is our patient navigator, who will sit with patients at this initial consultation and will start the process of helping patients work their way through the system.
Hi, can you see me?
Mm-hmm.
Yeah, I'm Pam Fitzgerald, and I am one of the navigators at Smilow, Trumbull, and Fairfield. I am a social worker, and what I would do is sit with the patient at initial consultation with Dr. Lynch, and get to understand a little bit about their social history and their family history, who their supports are. We would also review the distress screening tool at this time and see what, in particular, this woman, generally speaking, would indicate were her stressors, and we would try to help problem solve those issues. So for example, in a 62-year-old woman, we would talk sometimes about loss of loved ones. She may have recently had a family member pass away. Her children may be moving away. She may still be working and worried about financial stressors. So in that period of time, would talk about what supports are available to her in the community. We do have financial grants that we can help with. We can also help her with paperwork for work, whether it be FMLA or short-term disability. We also can refer her to counseling if it's felt that she would benefit from that. The integrative medicine services that we have available are numerous. We have support groups, dietary counseling. We have acupuncture and also massage. So very helpful throughout their course of treatment. But what's kind of unique to navigation is that we can travel, so to speak, with the woman throughout her continuum of care. So we can meet with her to discuss her options for treatment, but also explain why things are happening in a certain way, sort of in layman's terms. We're available. We tell them as soon as they walk out of the office, if they have a question, please call us. Call us tomorrow, call us next week, whatever we can do to alleviate stress. We can also meet with them with the medical oncologist and the radiation oncologist. And again, assess at that time. Oftentimes in radiation oncology, people have problems with transportation. We have resources for that as well. So again, we're here to eliminate barriers to care and to also help you from diagnosis through till survivorship. And, we'd just like to say we're, a new sort of friend that you would make, and please call us if you need us. And with that, I'll turn over to Amanda.
All right, we can go to the next slide. I'm Amanda Ganzak. I'm one of the genetic counselors. We have several who are staffed in the Bridgeport, Trumbull location. And basically what we do is help to review an individual's personal and family history of cancer to determine the likelihood that the cancers are hereditary, meaning a gene is running in the family, placing them and their family members at high risk for particular types of cancers. And with that information, we can then target and help the providers plan how to attack those increased risks, how to offer different surgical approaches, how to discuss various chemo prevention or other risk reducing options that might be available based on those increased risks. So if we take this case one as our example, some of the factors that I would be looking at in terms of assessing for the likelihood of a hereditary risk for cancer is the patient's own breast cancer diagnosis, although she was diagnosed after the age of 50. So that alone is not something that would highly be concerning for a hereditary risk. However, she has a family history of both breast cancer in her mother and pancreatic cancer in her maternal uncle. So we see two affected relatives on the same side of the family, combining both breast and pancreatic cancer, which for me are all red flags to see, to further assess this family for a potential hereditary risk. Next slide. So we utilize the NCCN guidelines, which are published on an annual basis out of the National Comprehensive Cancer Network. These are ever changing and evolving as new data and information is collected from our hereditary cancer families. So it can certainly be difficult to keep a bridge to these year to year, but that's what we hope to be there for, and particularly in tumor boards. So we help to review these guidelines and all the cases that are presented to determine how eligible someone may be for referral to cancer genetics for an evaluation and discussion of genetic testing. And so if you just hit next for me, please. In looking at this particular patient was diagnosed with breast cancer over the age of 50, and she has a close relative with breast cancer and a close relative with pancreatic cancer. So using these guidelines, we see that she does meet criteria for consideration of genetic testing. Next. And so historically, BRCA1 and BRCA2 are the genes that we see most often associated with hereditary breast cancer, but these genes cause other cancers like ovarian and pancreatic cancer. So for me, kind of top on my radar of assessment for this patient would be BRCA1 and 2. Although they are not the only genes that link breast and pancreatic cancer. The other genes that we might think about in this particular case are PALB2 and ATM. And so in the kind of world of genetic testing nowadays, we do what's called a multi-gene panel where we can test multiple genes for hereditary cancer risk. And I think that would be the best test suited for this patient. And she does meet NCCN guidelines. And so more than likely, she would also meet her insurance guidelines for genetic testing. And that test would help us determine, does she have a hereditary risk? Does she have future risks for other cancers that are higher than we would expect in the general population, or are other family members at risk? And so that testing comes back in a couple of weeks, and we can help facilitate that, disclose those results, and help facilitate next steps as needed. And so I'll pass it along to
Thank you.
Dr. Mastroianni.
It comes back to surgery.
Oh, okay.
So our breast surgery is certainly continuing to evolve as we develop new techniques to make sure that we are both curing the cancer and also providing patients with a good result, and minimizing the morbidity or complications of our operations or symptoms associated with them. And we've moved from mastectomy to being able to offer breast conservation or lumpectomy to more patients. And the pictures in the bottom show the difference between axillary dissection, which was the standard of care when I was a medical student, to now sentinel lymph node biopsy, removing only 1 or 2 lymph nodes at each operation, as you see in the picture in the lower corner. Next slide. And so now we've moved into the area of oncoplastic breast surgery, which is providing the best possible operation for patients to achieve a good cosmetic and functional outcome, as well as ensuring that we are providing the best oncologic outcome, that we are contributing to the cure of a cancer. Oncoplastic surgery often requires teamwork from a breast surgeon and a plastic surgeon working together to come up with the best operation for a patient, and also making sure that we understand what the patient's goals are. Next slide. This is Dr. Mastriani's slide.
Now I'll jump in. So oncoplastic breast surgery is not a cookie cutter operation. And as you can imagine, based on your tumor size and the ratio of that tumor size to the rest of the breast size, breasts come in all shapes and sizes in many different patients and women. So typically we're looking at a ratio of the tumor and the tissue that we need to remove in relation to the rest of the breast. Simple slam dunks are smaller tumors in larger breasts. Patients will hardly notice the difference if we remove that lump, and we may not necessarily have to do anything very complicated to yield you with a normal looking breast at the end of your operation. However, as you approach the 20 and 40% range, where you're going to be removing a significant portion of the breast, oftentimes, and the literature shows this too, it's important to consult with a plastic surgeon, because there are options that don't involve more surgery or implants or anything that's going to cause more scars on your body besides that lumpectomy scar. Occasionally we can do things to match the other breast too. So this is our sort of basic guidelines, where if you have less than 20% of breast tissue being needed to be removed, you oftentimes can close very simply, and you're not going to have a very cosmetically noticeable difference. As you approach the 20 to 40% range, there are a variety of different techniques that we can use to essentially squish tissue from one area into the area that is now a hole where the cancer used to be. Once we go beyond that, then you need to think about volume replacement, where we're moving tissue from somewhere else outside the breast to help fill in that volume and to make sure that you're in your own skin you look normal. Next slide, please. And as you can imagine, there are nearly limitless possibilities. So this is one of the fun parts of my job, where I get to talk closely and work with Dr. Lynch, where we figure out exactly where that tumor is and how can we best design an incision that's going to be cosmetically sensitive. It's not going to be right in the middle of your face every time you look at yourself. And that can easily be hidden in clothing. And also, how can we make this look nicer for you? Sometimes this often requires an operation on the other breast too to help it match. So these are just some examples of what we can do. Next.
So this patient had a cancer in the upper inner quadrant of the breast. And so we planned an operation to excise that, to remove underlying tissue, and to reshape both breasts in a breast lift type operation. Next slide. And so many studies have been done to demonstrate that this kind of approach to breast surgery is both safe from a surgical standpoint and provides a good oncologic outcome, that we can ensure that we are also curing the cancer in the same way that we would be doing it with a simple lumpectomy. So 2 large trials have shown that they're both safe and effective. And next slide. This is kind of a busy slide, but if those 2 last columns, oncoplastic breast surgery and therapeutic mammoplasty, the type of operation that we just showed you, also have the best patient-reported outcomes including sexual well-being, appearance, emotional well-being, and physical well-being. Next slide. So this was the outcome of the case for this patient, where the final tumor was 1.8 centimeters in size. We achieved clear margins. We did a sentinel lymph node biopsy, a limited axillary surgery, and the lymph nodes were not involved. Next slide. We sent a test called an Oncotype, and we'll move from here to the next slide into Dr. Fenn.
Hi, so as a medical oncologist, I typically will see patients such as this one who have small lymph node negative tumors that are hormone receptor positive, HER2 negative, to discuss treatments that we can offer to reduce the risk of recurrence long-term. And as a medical oncologist, I'm particularly interested at reducing the risk of distant recurrence. That means cancer outside of the breast, in the lymph nodes, lungs, liver, to reduce or increase the chance that patients will survive long-term cancer-free. And so for this type of breast cancer, one tool that we have to assess whether a patient needs chemotherapy is called the Oncotype. And we'll move to the next slide, and I might go back to this one. So historically, many patients with this profile were offered chemotherapy, but we now know that many patients, in fact, most patients with node negative, hormone receptor positive breast cancer actually don't benefit from postoperative, or what we call adjuvant chemotherapy, though there is a subset of patients that, that do benefit in reducing their risk by receiving chemotherapy. So our goal is to identify the patients who will benefit and offer them chemotherapy, and then reassure the patients who won't benefit that chemotherapy is not necessary, and the side effects that potentially could come thereof are we can avoid them by avoiding chemotherapy. So this Oncotype DX test is what we call a 21 gene recurrence score. This is a test that was developed by researchers by looking at a whole array of genes that are involved in breast cancer biology, and identifying 16 genes that are very strongly associated with breast cancer recurrence, as well as 5 reference genes. So when we send this test is a test sent on the tumor tissue. It's sent out to a lab, and the levels of those 21 genes are assessed. And then using a mathematical model, a recurrence score that ranges from 0 to 100 is resulted, as in that report that you just saw on the previous slide. So this test is what we call both prognostic and predictive. It can allow us to estimate the chance that cancer comes back in 9 to 10 years with endocrine therapy, which I'll talk about in the next slide alone. And then it can also predict, how much can we lower that risk by adding on chemotherapy to that pill that I'll discuss. So when this test was developed, it was shown when they looked at patients treated on previous clinical trials that there's a subset of patients with a high recurrence score who really do benefit from chemotherapy, whereas patients who have lower scores, the benefit's less clear. So with this Oncotype score result from 0 to 100, we consider up to 10 to be low risk, 11 to 25 to be intermediate risk, and 26 and above to be high risk. And so this, is validated in a clinical trial called TAILOR-X, in which patients who had low recurrence scores did not receive chemotherapy and did quite well long-term, whereas those patients who had high recurrence scores did, because we knew that already that these patients are at high risk of recurrence. And then patients with an intermediate score between 11 and 25 were randomized with flip of a coin to receive chemotherapy and followed by a pill, endocrine therapy, or endocrine therapy alone. And the results of this study show that for patients with a recurrence score of 20 or below, 25 and below, say, these patients did not, in general, benefit from additional chemotherapy after surgery. And so, I say here postmenopausal women, but really women who are over 50, like our patient here, with a recurrence score at or under 25, really we don't think benefit from chemotherapy. And you can see that on the report on the previous slide. They give an estimate of recurrence risk at 9 to 10 years. This patient's was 9%, and they estimated that really we can't lower it any further by giving chemotherapy. That was less than 1% benefit. For those patients, unlike our patient who are younger, under 50 years old, there might be some benefit from chemotherapy in the high intermediate range. And often we take into account other features such as the size of the tumor and the grade. But again, for this patient with a recurrence score of 23, I would not recommend adjuvant chemotherapy. So that brings us to a quick discussion about endocrine therapy. So certainly, though chemotherapy is not needed, adjuvant endocrine therapy will be a really important part of this patient's care. So by this, I mean a pill that's taken once a day for, we say, at least 5 years or 5 to 10 years, which yields a really significant reduction in the risk of recurrence by about half and death from breast cancer, and then has a secondary benefit of reducing the risk of a second breast cancer. So for postmenopausal women, just a really brief overview, a class of pills called aromatase inhibitors is really the preferred therapy to reduce breast cancer recurrence risk. Pills that many of you may have heard of in this class include anastrozole, letrozole, exemestane. These pills reduce estrogen levels. In general, these pills can be quite tolerable in many patients with no to few side effects. And side effects are often very manageable with various strategies. But it's important to know that they can carry some side effects. For these particular aromatase inhibitors, joint stiffness and pain may occur, as well as some hormonal-like symptoms like hot flashes and mood changes. We also look out for bone loss on aromatase inhibitors. This patient had osteoporosis, which is not in and of itself a reason not to offer an aromatase inhibitor, but we would want to make sure that we are working with her primary doctor or endocrinologist to make sure that we're reversing any other causes of osteoporosis, make sure that her vitamin D levels are optimized, and then also potentially offer an IV medication to enhance bone strength and reduce bone loss. The alternative endocrine therapy is called tamoxifen. This can be offered to either pre or postmenopausal women, but in studies comparing aromatase inhibitors and tamoxifen is slightly less effective in postmenopausal women. These pills can have similar hormonal-like symptoms and also carry a small but increased risk of side effects such as blood clots and uterine cancer. So really, this is a kind of personalized discussion with the oncologist and the patient to decide on endocrine therapy. But for this patient, I would potentially discuss with her an aromatase inhibitor. Then really briefly, in terms of how long do we treat patients for, our standard is at least 5 years, though there are many studies that are looking at or have looked at extending this treatment to 7 to 10 years. And in general, it's an area of controversy. These studies generally show that there's an increased reduction in the risk of recurrence by extending therapy. But this benefit might be more significant in patients who have higher risk disease. This includes patients with larger size or lymph node positive disease who we really might strongly feel to extend to 10 years. For this patient with a small node negative tumor, it's an individualized decision depending on how well the patient's tolerating treatment at 5 years. And I will mention briefly, there is a test called the Breast Cancer Index that is also a gene expression assay, similar in concept to the Oncotype DX score, which can sometimes allow or help for patients who are on the fence predict the risk of recurrence in the years 5 to 10 after treatment, and also predict benefit of extending treatment. And so this is something that is not right for every patient, but is something that potentially might be right for this patient if she's on the fence and continuing endocrine therapy at year 5.
Okay, I think I'm up. My name is Kevin Du. I'm the radiation oncologist here at Smilow Cancer Care Centers in Trumbull. And, I actually really liked what Pam said up at the beginning of this session about being a friend. I think that really the best thing about treating patients who are going through a difficult time is really trying to learn what the priorities are, what you hope for, and really being there to help you to try to get there. And I think that's exactly what friends do. So thank you for joining us here, for all the attendings for joining us here, and joining the panelists. The radiation therapy is used in combination with surgery in order to reduce the risk of the cancer returning after surgery. It's really enabled what Dr. Lynch referred to earlier, which is an approach called breast conservation therapy. That is, instead of larger surgeries like mastectomy, enabling patients to preserve their breasts and to still maintain the same cure rates as larger surgeries. And so it's been really a big advance in terms of combination therapy between modern surgeries, chemotherapy, systemic therapies, and radiation therapies. And that's been a huge advance in breast cancer care in recent years. As I'm showing here on the slide, we use radiation to reduce the risk of recurrence and to help cure cancer. But in addition, and very importantly for radiation treatment, as well as all our treatments, we also want to reduce the risk of side effects from treatment. And so this is very important. And in sort of my earlier comment about understanding patient priority, it's a very important thing to understand, the priorities and what a patient is hoping for out of treatment. And this is very important to tailor treatment around the relative benefits and the relative toxicities of treatment. For radiation treatment, what we do typically is after surgery, after systemic therapies, we treat the breast with X-rays, and we use X-rays to clean up any possible remaining cancer cells, maybe just a few cells that no one can really see, but we use radiation to clean up those cells. And what you're seeing here is actually a patient with similar to the patient that Dr. Lynch presented with a left-sided breast cancer. And what we're looking at here is a CT scan of the patient laying down on my radiation table, my treatment table. And we're looking at a CT scan where the patient is laying down on their back, and we're looking from the feet up through to the head in kind of bread loaf slices. And in the front, at the top of this image are the patient's breasts, and on the back, the patient's spine, and in the red contours, the patient's heart. And these black areas to both sides of the heart are the lungs, just to kind of orient you to what we're looking at. And you can see that close to the breast on the side of the left side where the heart is, the breast is actually very close to the lungs and the heart. And these are very important things that we pay attention to when we're thinking about how to aim the radiation, and things that we worry about when we worry about the side effects of radiation. There's some things that we can do that are very simple conceptually. Of course, we need to make sure that we execute them correctly in order to reduce the side effects of radiation. This is one technique where very simply we ask the patient to take a deep breath when we treat them with radiation. And you can see that by taking a deep breath, your chest expands And during the breath hold here on the right-hand side of the screen, you can see that, and I had arrows here, I apologize, I don't know where the arrows went, but you can see in the space between the breast, which is in pink, and the heart, which is in red, that that black area, the lung, expands out and puts more space between the heart and the lungs and the breast where I'm aiming the radiation. And so this pink line is actually an actual dose of radiation that I've delivered to a patient. And you can see that it very nicely avoids the lung, maybe just a little bit of catching the lung here and along the where you can see a little bit of the black area encompassed by the pink, and entirely avoids the heart. And so this is one technique that we can use to reduce the toxicities of radiation while still maintaining cure rates. Next slide. And then another technique that we use commonly to reduce side effects of radiation is to simply have the patient lay down on their stomachs instead of laying on their back. And you can see in the this pink foam board here, which this patient, where this simulated patient is laying on, is really is called a prone breastboard, and there's an opening here where the breast will fall into that opening and away from the patient's body. And you can see on the again on the right side of the screen where I have my radiation doses on again this CT scan, that treating a patient supine really while we're treating the breast well really captures a lot of this black area, the lung, and we don't want that. And you can see that by simply repositioning the patient, the breast falls away from the body in the lower panel, away from the body, and you can actually avoid entirely lung exposure by simple techniques like this. So next slide. So traditionally, radiation therapy would be delivered by over 6 to 7 weeks of daily radiation. And in recent, probably the last 10 years or so, because of advances in radiation, how we deliver radiation, better improved techniques, improved technologies, improved understanding of breast cancer biology, that we've been able to actually shorten that down to most commonly 4 weeks of daily radiation. Each day, each treatment of radiation is only about 10 minutes, but even so, with this reduction from 6-7 weeks to 4 weeks, you know, every day when I talk to my patients, I can still tell that 4 weeks is a lot of visits for them. In recent, just the last few years, there have been more of a data, more of a push, more clinical trial results, which support, in fact, perhaps even shorter treatments than that. Potentially even as short as 5 treatments for radiation treatments. I think the discussion here that I have with my patients is that probably the most standard treatment is the rather lengthy 4 weeks of daily treatment. However, in selected patients, and if it's right for them, you know, that potentially shorter courses of treatment would be appropriate and safe for them to choose. And I think the point here, as the slide alludes to, it's not a one-size-fit-all approach for radiation, and a lot of it is really as just with the surgical approaches and the chemotherapy, the medical oncology approaches, that it does depend a lot on the biology. You know, the discussion between all the folks on this panel, the medical oncologists, the surgeons, in order to come up with a tailored approach, and most importantly, the patients. And this again goes back to what I was first saying, which is, you know, it is very important to understand what the patient hopes for, what they're looking for out of treatment, and to be able to help them meet those what they need. So that's my take on the radiation, and I think in terms of all these different approaches, probably the 4-week regimen is what I would recommend for this patient.
All right. Can go one more ahead. We'll catch up to our next case. So in summary, this lady was treated with oncoplastic surgery, sentinel node biopsy. She got whole breast radiotherapy. She had an Oncotype test and then was treated with endocrine therapy with a high expectation of cure. And that we can move along to the next case. We'll come back to survivorship at the end. So the second case is a young woman. She's 38 years old who presented with a mass that she identified on her own breast self-exam. And she had abnormal imaging and a biopsy. And her only medical history is anxiety and depression. Next slide. Her family history includes a paternal grandmother with breast cancer, grandfather with prostate cancer, and she had a palpable mass at the edge of the areola, the pigmented area of the breast, but it wasn't pulling on the skin or the nipple, and she had no lymph nodes. Next slide. So the mammogram is done with you can see the triangle on the skin there that seems to overlie you can almost see a little triangle underneath there in the breast tissue. Next slide. And on ultrasound, there was a small mass and then another one right nearby. Next slide. She had a biopsy that showed that this was a breast cancer, but this was a different biology breast cancer. This was a higher grade. It was grade 3. And it was estrogen receptor negative. In fact, it was what we call triple negative breast cancer. There were no receptors that were found on the cell surface that regulating the cell growth. And the Ki-67 shows that this is a cancer where the cells are dividing very rapidly. Next slide. A breast MRI was done to make sure that there was no sign of disease elsewhere. And you can see, I see your question, I'll jump in a minute. You can see the tumor there that lights up. It's kind of whitish, and you can see the dark area in the middle, which is the biopsy clip. The other slide shows that this tumor is not close to the nipple, though. Even though it's near the center of the breast, the MRI is very helpful in very finely mapping the tumor extent, which can help us in surgical planning down the road. And I saw the question in the chat box about grade 3 versus stage 3, which is a great question. And you notice that we talk about the stage quite a bit in both of these cases. The stage of the cancer is determined by the tumor size, the involvement of local lymph nodes, any sign of metastatic disease, and then we take into account the receptors on the cell surface. The grade is how the cells look under the microscope and how big are the nuclei, the middle of the cells, and how rapidly are the cells dividing? Do we see things like mitoses, and how are the cells organized next to each other? So the stage takes into account all of these factors, and the grade is just how it looks under the microscope. Thanks for that question. Next slide. So this patient is still early stage cancer, like the other one was also stage 1. This is stage 1, but it's a different tumor biology. And so she then was brought to tumor board for discussion, and the discussion leaned towards chemotherapy as first course of treatment. Next slide. Back to Pam. So when we meet this type of a patient, what are some of the issues involved in navigation?
Mm-hmm. So, younger ladies have a little bit other issues going on, as a little bit different than our first case. She may have issues with finances and working, just like the other lady did. But But given her age, we would talk to her about fertility preservation if she's thinking about having more children in the future. And if she is, we would refer her to our endocrine reproductive endocrinology clinic. We would also talk to her about if she has children, how do you tell your kids you have cancer? And depending on the age of the child, we have different resources to help her to do that. But we also noticed that this lady has a history of anxiety and depression. So while we're always assessing for that, we would really be keeping a close eye on her, making sure that her depression or her anxiety aren't a barrier to her care. And if her depression was getting worse, we would make sure we would put the appropriate referrals in, whether it be to social work or psychiatry. We would also refer her to the psychologist. We also have different support groups for younger ladies. We have triple negative support groups. And we also know that our percentage of our triple negative ladies do tend to be African American. And there are support groups that are specific to African American ladies. So again, we would follow this woman very closely. We would meet with her with Dr. Fenn, most likely in a multidisciplinary clinic. And just make sure she gets to the right doctors at the right time and meet any of her needs that may come up. With both ladies, we would also be talking to them about sexuality and intimacy and how does breast cancer and the treatment of it affect them. So next slide, please. Thank you.
All right, so I want to take us into considerations for this case and whether or not she has a high chance to have a hereditary cancer risk. And so first, let's start with the fact that she has a triple negative breast cancer, which is definitely a more rare type of breast cancer and can be more highly associated with genes that cause a hereditary breast cancer risk. And she's 38. So that alone are two factors independent of any other factors in her family history that would qualify her for an evaluation and genetic testing. But she also has a family history of breast cancer in her grandmother on her paternal side, as well as prostate cancer in her grandfather. Next. And with triple negative cancers in particular, as much as 20% of these women, regardless of family history, will have a hereditary cause for that triple negative type breast cancer. So that is one reason which just within the last month or two, the NCCN guidelines have changed and now recommend that all women with triple negative type breast cancer, regardless of when they were diagnosed and regardless of what their family history might look like, should be referred and considered genetic testing. So that is certainly something that has changed based on our recognition of how what high percentage of these women have a genetic cause. Next. And so she would meet criteria, and we would definitely recommend that she come and see us and consider genetic testing. Next. And so in this particular case, my suspicion for a hereditary risk is really high. And so this patient undergoes genetic testing before she has surgery, let's say, and she's found to have a BRCA1 mutation, which is just a fancy way of saying she has a genetic risk. And BRCA1 is the gene in which that defect was identified. And so for this woman who has this new diagnosis of a triple negative breast cancer, these genetic test results now tell us that she has an additional risk to get a new primary cancer, so separate then from this new triple negative breast cancer. And that lifetime risk for her is 20 to 40% that she'd get a second breast cancer. Given how young she is, she's probably on the higher end of that risk range, so maybe even closer to the 40% risk. And so her options based on this risk might include increased screening of remaining breast tissue, depending on what surgical option is decided, or she might meet with Dr. Lynch and the plastic surgeon to decide that the best approach is to undergo a bilateral mastectomy, where we're removing both breasts, including the cancer that's there, removing the rest of the healthy breast tissue to reduce as much as possible that risk for the second primary breast cancer. Now, BRCA1 is also associated with ovarian cancer, and that risk ranges between a 40 to 60% chance. The hard part is that there's no effective screening to identify ovarian cancer at an early stage, meaning we caught it where we can easily treat it and have long-term survival for that woman. And so in the absence of effective ovarian cancer screening, we strongly encourage and recommend that women with a BRCA1 mutation elect to have their ovaries and both of their fallopian tubes surgically removed between the ages of 35 to 40 or whenever they're done with their family planning. And so certainly the breast cancer diagnosis is first and foremost in our priority in her care right now at this time. But this is information for future planning for us to think about after we get her through this stage, that ovarian cancer risk is the next thing that we should be focusing our attention on. And then with BRCA1, you can see a less than 5% risk for individuals to be diagnosed with pancreatic cancer in their lifetime. Although it's still rather low in all, most individuals with a BRCA1 mutation will not go on to be diagnosed with pancreatic cancer. And so pancreatic cancer screening has its limitations, it has its risks. We're still trying to prove benefit. And so we really reserve pancreatic cancer screening in individuals who have a BRCA1 mutation, but whom also have a family history of pancreatic cancer in a close relative. So in this case, since she did not have a family history of pancreatic cancer, we would not strongly encourage consideration of pancreatic cancer screening in her case. The next slide for the next.
So this is someone who in medical oncology I would meet, before surgery, and with an eye on time, I'll go through, how we treat systemically triple negative breast cancer and our thoughts about, timing of chemotherapy. So as we had mentioned, triple negative breast cancer is a subtype of breast cancer that can have a particularly aggressive biology and have a propensity to spread elsewhere in the body quickly. So this is a diagnosis where, unfortunately, because it's not expressing the estrogen receptors or another protein called HER2, we don't have traditionally targeted therapy, such as endocrine therapy that I mentioned in the last case, to treat these patients with. And so what we think of as traditional, quote unquote, cytotoxic chemotherapy, so traditional IV chemotherapy is really the mainstay of systemic treatment for triple negative breast cancer. And the vast majority of patients with triple negative breast cancer will need chemotherapy as part of their treatment. When we know that someone is going to need chemotherapy, we think about whether they would benefit from chemotherapy before surgery, which is called neoadjuvant therapy, versus going to surgery first and doing chemotherapy afterwards. But for patients with triple negative breast cancer, there are particular advantages of giving chemotherapy upfront prior to surgery. So these advantages include, for certain patients, especially those who have more advanced tumors, we can shrink the tumor with chemotherapy and may allow for less extensive surgery and improved surgical and cosmetic outcomes. But from my perspective in medical oncology, and more relevant to this case in this woman who has a relatively small tumor, is that giving chemotherapy before surgery allows us to assess the response to chemotherapy at the time of surgery. We know a proportion of patients will have what we call a pathologic complete response, or no active viable cancer cells in the pathology tissue at the time of surgery. And those patients generally have a good prognosis. For patients who have residual disease or active tumor still left over after preoperative chemotherapy, we know those patients may benefit from additional therapy after surgery. But we wouldn't be able to identify those patients unless we gave the chemotherapy up front and assessed the response. So when we think about who should receive neoadjuvant chemotherapy for triple negative breast cancer, certainly this is the standard of care for more advanced early stage breast cancer, such as stage 2 and 3. But when we know, patients are going to need chemotherapy, we will, certainly consider it preoperatively for patients who have slightly smaller tumors, including this patient who has a tumor between 1 and 2 centimeters. Certainly, she's young, she has aggressive biology, she's a candidate for chemotherapy. I would advocate for her to receive chemotherapy before surgery so we can assess response. And in my next slide, I'll explain, potential options for her after chemotherapy if she doesn't have the optimal response at the time of surgery. And when we think of postoperative therapies for residual disease after neoadjuvant chemotherapy, I wanted to mention, two options just to make aware of, options that would be available to her if she did have a suboptimal response at the time of surgery. This includes briefly oral chemotherapy called Xeloda, which we know improves disease-free and overall survival in triple-negative patients with residual disease. But for her situation in particular, where she has a germline BRCA1 mutation that she inherited from her family members, there is a drug called olaparib, or brand name Lynparza, that's in the class called a PARP inhibitor, which prevents, in general terms, prevents cancer cells from repairing DNA damage, leading to cell death. And the patients with BRCA mutations are particularly susceptible, their tumors are susceptible to this drug. And so we have a recent study that came out just over the summer called the Olympia trial that notes that adjuvant olaparib can improve disease-free survival in patients with high-risk early breast cancer and BRCA1 mutation. And so if she had residual disease at the time of surgery, she could potentially benefit from this drug. And that's pretty new development. And that's all I'll say to preserve time.
It's very exciting, those changes. I mean, thinking about it in the course of my career, how treatment of women with triple negative breast cancer has improved is really, really thrilling. So this patient, because she has a BRCA mutation, elected to have a bilateral mastectomy. I just wanted to comment briefly on nipple sparing mastectomy, which she is a candidate for. This is a technique for both treating breast cancer and for doing prophylactic surgeries. And it allows us to preserve the entire skin of the breast, including the nipple. This picture, which is from a research publication, I think really gives a wonderful picture because patients often don't understand how we do the operation through a very small incision underneath the breast, where we're able to remove all of the breast tissue and maintain all of the skin and provide exposure so the plastic surgeon, my partner, Dr. Mastroianni, who I've done a few of these cases with, can then place an implant or can even use the patient's own tissue to create a reconstruction. These really require, the breast can't be too large, so we have to choose the right patient for the right operation. And it's also better for patients that are not smokers. Next slide. And the outcomes are safe. And so there is both a registry and a large review of multiple studies with multiple patients that show that these are both safe from a surgical perspective and from a cancer perspective, and that we can still achieve a cure using these new operations. Next slide. Dr. Bastriani.
I forgot I was on mute.
Oh.
So in general, when we remove the whole gland, what you're left with is a skin skeleton or a shell, basically. So we have two different options currently available to fill up that skin envelope. One is with using an implant, and that's something that we make synthetically. It is made of silicone. All of them have silicone shells. Some of them can be filled with silicone gel itself, or they can also be filled with saline, but all of the shells have silicone on the outside. And it's something that we've studied for the past 50 years, and we know that it's safe. The other option is that we can fill in your skin envelope with your own tissue. And this is not an implant. You don't have to take any rejection medications for this. It's your body. It's going to feel the most natural. Next slide, please. The two different kinds of implants that we can do, you'll notice on that former slide, there was a 1-stage and a 2-stage. The 2-stage is where I have to put in a tissue expander, which is the device you see on the left. That is an inflatable expander. It allows me to add more volume or take it away as we need to, based on how your wounds heal. When we do remove most of the breast, you're removing about 80 to 90% of the blood flow to that skin. So I want to make sure that you heal well. So this I guess, adjustable implant allows me to tailor make your reconstruction for you. It also gives you an opportunity to try on the size, and you can walk around with that size in your body and decide if that's what you really like. Oftentimes, and more often, we're able to go directly to the implant, which is what you see on the right. And as you'll notice, it's not a round sphere like a water balloon. We've also come a long way as far as implant technology to make it more breast shaped and to help it move more fluidly with you and to feel more natural under the skin. Next slide. And then finally, I just wanted to talk briefly about using your own skin. This is probably or your own tissue to reconstruct. This is probably the most popular option, and it's been around for more than a decade, but we're now becoming more facile and it's becoming more mainstream. More people are training to do this kind of procedure. It is a bit more involved. We can't just move up skin and fat from anywhere. It actually has to come with a blood supply to it. We need to nourish that area. So one common place that we take this extra tissue from is the lower abdomen. Oftentimes women have a little bit of extra fat down there. Perhaps they've had pregnancies and they have a little extra skin down there that is hard to exercise away. So those kinds of patients are ideal candidates for this. Even if you've had a cesarean section, you're still a candidate for this. So we are able to trace all of the blood vessels down into your groin and reconnect them up in your chest using a microscope, and we use sutures as fine as hair. So this is an intensive operation. It does require special training, but a place like Yale, we can offer services like this. We can offer a whole range of reconstruction options. And then the beauty of this kind of reconstruction is you don't need any long-term follow-up. With implants, I tell my patients it's a lot like getting an oil change. You're going to come in every 10 to 15 years to get the implant switched out. And while that's an outpatient surgery, it's still another surgery. Whereas if you undergo this option, you're done with reconstruction for the rest of your life. You don't need to come in for oil changes or anything like that. Next.
So our patient had that operation. She had an implant-based reconstruction. Next slide. And she had a complete pathologic response. So she had a tumor there. She received her chemotherapy. And then at the time of the surgery, the tumor was gone, which tells us that she'll have a very good prognosis and that Dr. Fenn saved her life. So next slide. So we're at the end of our time. And so maybe let's make sure we've answered any questions, and then we can talk about issues in cancer survivorship. Were there any other questions in the Q&A or in the chat box, or any questions you'd like to ask us now?
One question was whether the video will be available, and it will absolutely be available on the cancer YaleCancerCenter.org website. So you guys can have access to this video and you can review it. And if you have other questions, you can email us at canceranswers@yale.edu. You can also call the Trumbull team at 203-254-2381. And those were the only other questions I saw. We had a few Q&A that we answered by writing the answers. To the panelists, any remaining words before we break for the night?
Good job. So proud to be part of this team.
I think what you all did tonight is highlighting how multidisciplinary breast cancer care is and how we all need each other's expertise to deliver the best and most optimal care. And at the center of the team is our patients. So I want to thank all the audience members tonight who joined us, and feel free to email, call. We want to hear from you, and thank you again. Have a great night.
Thank you, everyone.
Thank you.